Good afternoon, everybody. Welcome, board. Welcome to our member of the public. So this is the meeting of the board of directors in public, and we'll just go straight into the agenda. The meeting is going to be recorded, so you know, and be up on the website in 5 days' time. And on this occasion, we won't be presenting a board story. We'll be doing that next time we meet. Apologies of absence. We have Nitin Mehta, one of our non-executive directors. He's the only apology we've had. And declaration of interest, please. Is there any declaration of interests on the agenda items that we need to log and register? Minutes of the board of directors held on the 4th of December and the actions and matters arising. Firstly, let me seek approval of the minutes, if I may. I'm sure you've all had them, and an accurate record. And I'm pleased to say, as we see in the papers, all of the actions have been completed. We don't have any questions from members of the public, so if it's okay with you, we'll move on to the chair's report. And yeah, the report's there, so you a look at that. It's been another active period of time since the last time we met as a board. I described there the provider collaborative. This is the Sussex provider collaborative, which involves the acute primary care, mental health and autism. So we're very much part of that. It's been developing for some time, and there are 3 areas of work that I particularly want to point out. Frailty. So this is the group of organisations within the integrated care system coming together to prioritise some work to improve, and frailty is the first one, and then closing the morbidity gap for people suffering from serious mental illness is another one, which is really obviously very important to us, and we'll be taking the lead on that. And then the other one of note is to shift the emphasis from hospital to community, which of course is in line with the government's objectives, and very much part of our strategy going forward is to develop, build up community services. The other paper I'd like to make reference to is the government white paper on English devolution. Critical and very important for us to monitor and discuss the implications for us. And the cabinet of the 3 upper tier council have submitted an expression of interest as an early adopter, which of course is indicative and it's significant. We will need to keep a very close eye on that and be involved in the discussions. So strategically, that the notion is that there'll be one mayoral strategic authority with a mayor of Sussex across the Sussex patch, concentrating on economic growth, jobs and skills, housing and transport. Again, all of those areas we have links to and can make a difference with, for example, economic growth and the work we've been doing on housing and mental health to develop our services going forward. Also, just to, from a very positive point of view, the mental health investment standard, as I've said in the report, remains. There were some discussions and I think some fears really within the mental health sector that the mental health investment standard wouldn't continue. It's really important for us, although we do have an integrated care system who completely get mental health, prioritise mental health, but it's really useful to have, and that's sort of protecting the finances for the mental health services as we go forward. And then lastly, just to make reference to and give a bit of profile to some visits we've had of late and to our services and meet the board as well. The Health Service Safety Investigatory Body came to see us. They have a particular remit to investigate and do some work around acute mental health inpatient units, as well as all the other things that they do outside mental health. This is a mental health focus, and we invited them to have their board meeting, and we met them as a board to board. It was a really useful discussion, and you can imagine we were obviously concentrating specifically around safety, briefing them of our strategy going forward, and they were very helpful. It was a really constructive meeting. And the other, we welcomed Lord Victor Adebowale, a peer and former non-executive director of NHS England and now the chair of the NHS Confederation. He came and saw some of our services and again met with some representatives of the board. And I think it's useful for us because we're working on a 5-year strategy where we're building up our work now for the next few years, and it's really useful to have a discussion with key players at national level to sense check. Have we got things right? What are we missing? And I think it's fair to say that Lord Adebowale was rather impressed with what we're doing, our change programme going forward, and the challenges we had with finances were all rehearsed and discussed with him. And then finally, just a couple of days ago, Andy Bell, Chief Executive of the Centre for Mental Health, came and joined us for half a day to, again, have a discussion about our strategic approach. Andy is a great policy expert in mental health at national level. Very useful to have him. So those are my points that I wanted to highlight from my report. I'm happy to take any questions or comments. Lisa.
Thank you, Sean. So just one comment on the HSIB visit, so the board to board. So colleagues will remember that the Director of Education board to board, and we are working closely with HSIB now to arrange the delivery of training for the team that will be working to oversee the patient safety investigations for the organisation. So as we move to the centralised patient safety team, the HSIB will be supporting us to deliver training to those new team members and indeed existing team members as we move to the centralised function. I wanted to update colleagues on that because that was a great offer, one that we absolutely need to be taking forward as we continue with the improvements to how we take timely learning from patient safety investigations.
Jane.
Just thought it might be worth for the public. HSIB is Health Service Safety Investigation Body. Yeah. So.
Anything else? Okay. So moving on to the Chief Exec's report.
Thank you. I will take the paper as read and won't go through the detail and answer questions, but a few things have happened since the paper was written. But I first of all do want to acknowledge that Adam Doyle, the System Chief Executive, has left for a national role, and thank him for his contribution to Sussex and to personally to me, supporting me as a new Chief Exec in role over the last 3 years, and for ensuring that mental health and learning disability stays safely high on the agenda for the system. And I know Mark Smith, the new interim chief executive, is of the same mind, of being really clear that mental health and learning disability and neurodiversity is really at the forefront and has equity across the portfolios, which is really positive. The other system announcement was in the HSJ yesterday. Jane Black has been appointed as the chief executive of East Sussex Hospitals Healthcare Trust, sorry, ESHT. So we have 2 Jane chief execs in the system, but Jane is fantastic. She's worked in the system before. She has worked both at ESHT and at University Hospital Sussex in executive roles, and she comes from Medway, where she's the chief exec there. We haven't got a start date for her yet, but she will be joining the Sussex system. There was one additional visit we had. We had Becky Cooper, the local MP for Worthing, come and visit us at Meadowfield. And this is part of a cross-party MP visits to our services. So when the election, after the elections, we invited every MP that served Sussex, East Sussex, West Sussex and Brighton and Hove to visit our services and to meet with us, and a number of them are taking us up on that. We haven't been able to do them all in one big group, so we're doing it, we're being pragmatic about it. But Becky came and visited us last week. She's a public health consultant background and is also on the Health Select Committee, and asked a lot of questions that you would expect around neurodiversity, CAMS, pressures in the acute trust, finances and devolution as a previous local councillor, and is very keen to come and visit again when she's her diary enables her to. The other main news that came out after my report came out is the planning guidance came out last week, which was sent to you in the was sent to you at the end of last week, and we will be going into more detail in the next couple of weeks about what that means for us and the implications for us. I think my take on it is that it's welcome that there are a narrower number of performance metrics that we need to report on. Mental health has its own section, but very targeted around access to children and young peoples and waits in 12-hour waits in the emergency department. So really in line with what we are planning to do as part of our strategy. So it's really good to see it's aligned, and also financial recovery. I think for us, the two biggest challenges are the 12-hour waits in ED at the emergency department, and ensuring that we bring those to as close to zero as possible for the residents in Sussex, and ensuring we get to financial stability in the long term as stewards of public funds and being able to use our finances wisely. And that nicely moves into our strategy launch, which will be in April, but during this month and next month, you will start to see it beginning to filter in the sort of the communications and paperwork that we use, and using the values. We're starting to warm it up and use it now ready for the launch in April, and we will be having an event where we're going to be launching it, which you will all be invited to and we'll make known about. So it's very exciting. It's very ambitious strategy for the next 5 years, and if we achieve the ambitions of the strategy by 2030, I think we will all be able to look back and be very proud of what we've achieved to the people that we serve.
Thank you, Jane. Okay, let's take some questions. Dinesh.
Just on the flu thing, I'm sort of, you said in the report, Jane, you said that 39% of trust staff had received a flu vaccination directly from the trust. Do we know if they had had vaccinations elsewhere, or is this the bottom line?
There will be people, Teresa might be better to speak to this, but there will be people in that have been vaccinated that we don't know about. These are the ones vaccinated by us, but I'll let Teresa take it.
Thank you, Dinesh. So an example, I think, of the question that you're asking would be trust employees that have had a vaccination, for example, with their GP. So we do have some recording, but we are improving our recording position for those staff. So we're in the process of setting up, with support through the communications department, a QR code that staff can log on via to register where they've had their vaccination in different parts of the system outside of SPFT as their employer. And then as we prepare for next year's vaccination campaign, we'll be ensuring that that's well embedded from the beginning of the campaign.
That was my point, because even if we, I mean, in other trusts, it's kind of 65% plus take up rate, people who are vaccinated, so which is still not enough, but it's kind of much better than 39. So maybe another 10% would have.
That's right, and we are slightly below the average across Sussex currently, and we're performing top for COVID. So for flu, we're about 1% below the average for the Sussex system, and for COVID, we're performing top at 33%.
What should we be doing?
Well, one of the main things that we should be doing is exactly related to your initial question, which is around how we record where staff that have had their vaccination outside of SPFT as their employer. That's the action that we're taking as a priority action in the first instance. And as we prepare for next year's campaign, that will be one of the programmes of work that we set up from the very beginning of the campaign.
Thank you.
Thank you. Please, yeah. Alan.
Chair, Jane, as always, thank you for your paper and what you've set out so helpfully. For colleagues to orientate yourself, it's paragraph 1.2 and it relates to service transformation. You say quite rightly, Jane, that we need to be mindful of the impact upon staff. The question to Lind, if I could, are you able to provide a very brief thematic overview of those concerns that have been raised to date? Also, given our oath to the people promise, as well as it being a legally obligated process that has to be, amongst other things, genuine, meaningful and timely, what assurance can you provide us that we're seeking to address those concerns that have been raised?
So the themes I would I would say that this is not scientific. Which is why I'm hesitant. So when the consultation started, the themes that were coming out were very different to the themes now. So I would have said the themes to start with were, I don't agree with what you're doing. I don't agree with the model. I don't agree with what you're doing. As time has gone on and we've worked with that, that seems to have quietened down, and it's now more, you haven't communicated very well, and I'm worried about my job and I'm worried about my future. So there's been a transition over the time, and we've reflected as a team, because we're going to have to do more next year. What have we learned this year? I think we've learned that we thought we were communicating well. We thought we repeated things 100 times about where we are with our finances and why we need to do this. It didn't necessarily land in the way we expected it to, or people heard it, or whatever, for all sorts of reasons. It didn't land in the way that we hoped it would, and so what we've talked about this time is having really targeted conversations with groups of people with a really clear narrative about how did we get to this point in our financial situation, and what journey we're on, how far we've come and what we've got left to do, and doing it both in terms of the traditional communications, as in webinars and newsletters, but things like Usman's going to the medical advisory committee with Oliver next week. Thank you. Next week, to have a conversation and discussion with them.
Yeah.
So thinking about what can we learn from last time to do differently, so that those messages, we deliver them in a way that people find helpful, bearing in mind that there will always be people who are cross and rightly upset by the changes we're doing, and that is a human reaction, but we do want to meet people as close as we can. And Anil, I can't remember the second question. I'm so sorry. I should have written it down when you said it.
You trespassed on both, actually.
Good.
Can provide you
Yes.
assurance.
Yeah. Thank you.
Did you want to?
Well, no, it was just the assurance point. I was just going to add, I think one of the ways we could demonstrate the assurances based on the initial consultations. We then did make changes to the subsequent things that we did, and we listened to people, and we openly said, when we did the consultation, it isn't we haven't just put something out and it's done. We listened to it. I know Oliver and Teresa and many of the team, and John in particular, met with lots of people, took the feedback, and then we made the changes in the final consultation that hopefully represented one of those things. And just one last thing I was going to add, a lot of the feedback that I think we did get was around the speed with which we did it. And I think, there was no way of always getting around that. The challenges that we faced were quite significant, and they're going to remain significant. And so I think the communications point is how we have to help balance off against the need to do some of this stuff relatively quickly. And I will say, just to balance it out, we did, while some staff did feedback that they felt it was quite quick, others appreciated that we had done it quite quickly and given people certainty, so that they weren't left for many months without knowing what was going to happen. So, yeah.
So smooth transition into our communications lead. Who wants to talk?
It was just a couple of points to add, Chair. One, and it's a really important question. During this period of change, significant change, we had really good engagement from staff and patient carers and partners in the co-production of our organisational strategy. It's really important we continue that engagement work as we move into the delivery phase from April. And then the other point I'd add is that obviously the results from the NHS staff survey, when they're published in March, will be an important measure for us in relation to staff experience.
I wanted to just link in off the back of what Usman said. So there's a core part of what we were trying to do, which was the recognition that the change is having patient safety and outcomes at the forefront of it. So the models fundamentally has that at the heart of it. And it's really important for us to put that front and center and then say what's the most effective model structure that we need to have to help us deliver that. And that's where the savings come out of. One thing that's been at the heart of the entire savings reduction when it comes to the modeling has been to keep redundancy at a minimum. And it's important for those who are in our appointments and remunerations committee. We have an absolute commitment to minimizing redundancy. So that will add to the to your question around assurances around what are we doing. We're holding up what's the most effective structure as our true north, as it were. Or whilst doing that, we're trying to minimize redundancy because we have held quite a lot of vacancies through the year. And our job now with the new structure where we've done those changes is to start looking at how we can keep people together. So that's also another dimension that's not just about, it's not about kicking people out. It's what's actually best for our services, for our people, which then ties into the vision of the new strategy.
Thank you very much from me. And Dan, you mentioned about our consultation on our strategy for staff and services, also carers and family. Need to commend the staff on that, and it links to the part of the report of Triangle of Care that we successful in maintaining our 2-star membership of Triangle of Care accreditation scheme. And one of the things they highlighted is the co-production, the involvement of carers within the work we do, and that is a vital part of our work. And when we're looking at driving up quality to, at a very early stage, have good relationships with families and carers, very important to us. So that's good to see that. Any further comments? Thank you very much. But moving on to performance and risk. And the first paper is the Integrated Quality and Performance Report.
Thank you, Chair. So you will all have the report and had a chance to look through it. So I won't go through every point in detail. I will just highlight some of the sort of key things, and then in a bit of a change to how we've done this before, rather than me just try and cover everything off, I'll go to my colleagues to cover off the relevant sections around quality and performance. So I guess the key thing to highlight is that there hasn't been significant change in this month's IQPR since last month. We continue to face challenges in certain areas, and those have been relatively consistent across the year around risk assessments and wait times. And I'll talk a little bit about those in a second, but then John will go into more detail. We also have had significant improvements over the course of the year, but those again have been consistent and been building through the course of the year, whether they're related to agency spend. We're continuing to see an improvement, even if it's a bit marginal, around clinically ready for discharge and PROMS recording, which has been improving through the course of the year. Just a couple of specifics, I guess, given the conversation we're going to have about the strategy and things that we talked about in terms of the patient reported outcome measures, so the PROMS score. At the start of the year, we were at 16%, and it looks like we'll finish the year about 35% and currently about 33%. So still quite a lot to do, but a really significant improvement in that. And equally, we quite often talk about paired PROMS and CROMS, so paired patient reported outcome measures, but also clinically reported outcome measures. And those have improved from 8% at the start of the year to 16% in December. And we're hopeful that we will get close to our internal target that we'd set ourselves of 25% by the end of the year. And that, again, we recognise there's quite a long way to go, but that's a big improvement from where we were and kind of ties into the conversation we've been having about the strategy and some of those outcomes and why they're important. The two things, I guess, to highlight that are different in terms of things that have deteriorated, where there's some concern, and colleagues will come and talk about it specifically, but our complaints response in December did drop to 77%. And I'm happy to say that in January, based on our initial numbers, it is back on track, but we expect that to be variable over the course of Q4, and I'll let Dan sort of come in to talk about sort of the details of why that will be. And again, we have had some challenges around the PSSIs, but Teresa can talk about sort of some of the actions we're taking to try and address those, and sort of we've recognised the challenge that there is around our need to be able to respond in a timely way on those. A couple of other quick bits I just wanted to pick up before I turn to colleagues. So again, given the discussions we've been having around wait times and the focus of the work, we have sort of consistently through the course of the year talked about the neurodevelopmental weights. That position continues to remain significantly challenged. It's in line, sort of, as has been widely reported nationally, as an issue. But outside of that, I think it is important to know that, for example, on CAMS, we started the year with 117 people over 52-week weights. We ended December at 13 people over 52-week weights, and we're confident that there's a plan in place that will get to 0 by the end of this financial year on that. And equally for adult non-ADHD weights, very significant improvement since April, where we're down now to, I'm exactly in front of me, I think it was 7. So significant work has happened within our sort of waiting list work. John and the team do an incredible amount of work through the waiting list program boards to manage all of that, but we recognise we have got an ongoing issue with DND wait times. And then, just because we have always sort of flagged it, there was one breach of the CYP-ED urgent standard. That was one patient, and the breach time was 1 day. And that was, and it's not an excuse, but I guess it's the referral arrived the day before Christmas, and I think there was challenge within the team to respond, but it was dealt with in 1 day after the allocated 24-hour period. I'm going to stop talking there. Before we go to questions, if it's okay, Chair, I'll just go to Dan first on complaints, then Teresa on PSI, and then go to John for balance of performance things around what you might want to raise.
So on complaints, our focus remains on timeliness, tone of voice, clarity of content. As reported in the packet, we were below target in December. And we've been below target for 3 consecutive months. We did improve the position in January to 89%. It remains a challenge, not least because of the new policy we introduced in September. We're now taking the complaint investigation outside of the service concerned, where early resolution hasn't been possible. So this is a new way of working, and it is a challenge for our divisional teams. There are 2 positive points I'd make. One, we are now consistently resolving around 20 or so complaints a month through early resolution, and that means having a conversation with the complainant before we provide a written response. So this is the direct result of the change of policy we introduced about 18 months ago. So that is a positive. And secondly, I just wanted to advise the board that, as previously discussed, we're exploring the use of AI, both in terms of how we might triangulate complaints related and incident related data more effectively in order to establish themes and hotspots, but also how the potential for using AI to improve our processes to help us really focus on that response rate.
Thank you. So I'm going to talk about the patient safety incidents and the investigations. So colleagues will recall that some months back, we were reporting 50 breached PSIIs, patient safety incident investigations. And what we mean by that is that when a PSII is declared as a patient safety incident investigation in terms of the threshold being met, and for a full investigation into a patient safety incident, but we would complete that incident within 90 days. The national target does speak about 90 days, but also with an absolute maximum of no more than 6 months. Our internal policy is 90 days. For some months back, we were reporting 50 breached, and I really must stress this. The absolute focus here is on ensuring that patient safety investigations result in timely learning, timely actions to give us best chance of the avoidance and the minimisation of incidents like that happening again. That families that are often grieving the loss of their loved one are receiving those reports in a timely way, and that it's not impacting on coronial processes. So that's where my focus is. It's on the families. It's on making sure that the learning is really timely and that coronial processes are not delayed as a result. For some months back, it was 50. Currently, as I sit here now, it's 35. So we have 35 breached reports currently. There are a number of things that we have put into place in the last few months. Mandatory support sessions for authors, so the colleagues that are completing those reports and those investigations. And moving into this month, we're setting up a range of panel review sessions so that ultimately I'm there, Oliver is there as the Chief Medical Officer, and that we will be as a group reviewing those reports and signing them off in a timely way. Is this where it ultimately needs to be? No, it's a very, very significant focus for the executive team. Of course, it is for the clinical governance and quality assurance team. We have a weekly report coming through executive committee, and we're working really hard to achieve the trajectory of 0 breached PSIIs by the end of February.
Very good. And John.
Thank you, Chair. I'm sure colleagues will have a number of questions, but just to draw out a couple of areas. Usman's already described the 52-week wait improvement in CAMS, with a small number of young people waiting still longer than we would like. And as Usman said, we will hope to see that resolved by the end of the financial year. And from a sustainable perspective, that is something that will be picked up in our focus on productivity in next year as we start our CAMS transformation in earnest. Clinically ready for discharge, an area we talk about in this group a lot. We have seen improvements in that area, predominantly in West Sussex, and a note of thanks to West Sussex County Council for the level of support that they've given us. I think it's also important just to recognise that the scale of the delays in some areas are still significant. We're seeing very significant delays with very long periods of time, particularly in Brighton and Hove. Talking therapies, you'll see in here that talking therapies is described in a number of ways. The focus that we have been discussing with NHS England and subsequently NHS Sussex has been around completed treatments. So the most significant action that we've taken is to outsource a significant number of delayed assessments within the Brighton and Hove service to an external provider, and that activity is now taking place in Q4, and we will see the impact of that over the remainder of the year. Memory assessment services. Again, colleagues will remember that we paused our memory assessment services this time last year for a period of 3 months, and that led to an increase of the waiting list. We did that to support winter pressures across the system and to minimise our use of temporary staffing. We have spent some considerable time looking at our productivity metrics, particularly in West Sussex, where the bulk of our memory assessment services have done, and we shared with our commissioners yesterday our trajectory for improvement around those waiting lists. We will continue to have waiting lists, but we will be able to provide more capacity within those services over the next few months. Usman's already covered neurodevelopmental services, and happy to talk about that further if that would be helpful. One final point. The report mentions that we are in the top quartile for out-of-area placements. Out-of-area placements are reported by bed days. So when you look at the graphs, you may look at it and think, oh, that looks like a lot. That's a bed days number, not a number of individual patients. At the point in time, we had 3 out-of-area placements. We now have 1, and that was specifically related to psychiatric intensive care unit capacity and supporting patients who were waiting in acute trusts. We did not want them to wait longer than needed in an inappropriate environment. I'll pause and take questions on any specifics.
Thanks for the clarity on the out-of-area placements, because nobody wants a situation where people are transferred hundreds of miles away from where they could get their community support and prepare better for discharge when it comes. I just wanted to say that you both mentioned, Usman and John mentioned our neurodevelopmental waiting times. This is a serious issue for us as an organisation. It's a serious issue for the integrated care system, the wider group of organisations across Sussex, and we're working on the early stages of the right models, effective models to address this. Our Chief Medical Officer is best placed and doing a really good job on leading that with our partners throughout the system. I suppose what I'd like to say is just to log that we're working on it, but it's really, and we I don't want to put you under any sort of undue pressure on time, but when there is a scoping of the model that we could bring back here to just present, that would be really useful, Oliver.
Yeah. Do you want me to just say a little bit about where we got to now? If that'd be helpful. So we've been working with the ICS and partners, and just to go down into the detail a little more. So our West Sussex approach is a more mainstreaming type approach, and the waiting list there is about 1,500. Where we have a specialist model in Eastern Brighton, that's where we have the more significant problem in terms of waiting lists. That's where we've got something like 15,000 people waiting. So we've been with quite advanced discussions. We're standing up a clinical design group to scope out exactly the detail of that model. In short, it will rely heavily on a primary care assessment and treatment, but then escalating up into secondary care and specialist services for those more complex problems or comorbidities. And so it should provide a much more flexible approach. The event we've got on the 12th of February, which I mentioned earlier, we're going to start socialising the model with the medical workforce there. But I'm hoping later in the year we'll have a funded model that we can then bring here and describe in more detail.
Okay, thank you very much. Good. So we move on still with Usman, the board assurance framework.
Chair.
Forgive me, Chair. Is that discussion only or questions?
What?
That aspect of the agenda open to questions?
The discussion we've just had?
Yes.
Yes, please.
Sorry, I didn't know if it is, then that's okay. So just a few things come to mind, if I could, with your forbearance. The first thing, PSIs. So it's helpful to hear that candor. Thank you. It's not where it needs to be, but also that it's a priority for the executive team, and also the focus is on families, learning process. I think at the same time, alongside the key actions that have been taken and continue to be taken, that it'd be good to understand as a board what actually gives rise to those delays in the first place that prevents us to synthesize information to then promote timeliness of safety improvements, without which, certainly speaking for myself, I think we're unable fully to a board to establish whether the actions are commensurate with the issue. Does that make sense? So I suppose that's my first question, if I could.
So until now, the way in which we have completed patient safety investigations is that authors have been identified as colleagues, senior clinical colleagues that are working in divisional teams. Going forward, post the corporate services review, we will be having a centralised patient safety team. That gives us many advantages because it means that we can, as I said earlier, actually, when Sean was presenting Chair's report, we can ensure that those staff have the most current training according to the patient safety incident response framework, that those staff can be supported with their well-being, because the staff that are working to complete investigations face trauma on a daily basis, so we can make sure that those staff are supported both from an emotional wellbeing perspective and in ensuring that the PSERF model is followed in the completion of timely reports. Now, what that doesn't mean is that clinical colleagues working in divisions won't have input into those reports. We absolutely will be relying on specialist subject matter experts from within the divisional teams according to the investigation that is required. So we are changing how we operate the investigation process and the model via the corporate services review. That's going to be resulting in a number of new investigators coming to work in the team. I'm pleased to report that we've recruited 75% of those, and that the model is being stood up, that the new centralised model is being stood up as I speak. So I predict that we'll be able to work in full to that model in the spring.
Thank you, Chair. If I could, a second bit, going back to something we've discussed, timeliness of care plans. So again, to orientate yourself, colleagues, it's page 4 of the 49-page report. I'm conscious of those key actions that help the trust journey towards a certain target. But whilst we journey towards that, how, if at all, are we able to disaggregate those who are most vulnerable? For example, only children in care, who, without timely care plans, we know, don't we, that face significant harm, lifelong adverse sequelae. How do we prioritise, how do we disaggregate those vulnerable groups and promote or prioritise timeliness of care plans for those groups?
That Teresa?
So for example, if we take the learning from the Nottingham review in relation to Valdo Calico, And I know that that's hit the headlines again for understandable reasons this morning. How do we ensure that, for example, patients with serious and enduring mental illness have a care plan and a risk assessment in a timely way that is meaningful to them and their care networks? That is part of the work of the Task and Finish group surrounding the learning from the Nottingham Review. So I think that's one point. As we continue to be more sophisticated in how we are able to present our data, this is certainly something that we will be looking at. So at the moment, we can break down the care plans and the risk assessments into the care pathways, into divisions, specialist services, for example, we can drill down there. But I'm not confident, and John, you might be able to help me with this, to say that actually we can be very specific about the number of children in care that have particular. So I know it's an example, but I think it's a good challenge, and I think it's something that we need to think about going forward. So I'm confident that we are moving in the right direction, certainly on the back of the learning from the Nottingham Review. I think the challenge is helpful in helping us to go away and think about what other specific groups of particularly vulnerable people, children and adults, can we be assessing this data against? I think that's a good challenge and something we need to take away.
It's a very good challenge because other people want to come in. So let's, Jane, John and Dan.
So I think it's a brilliant challenge, particularly as I used to be looked after children's nurse, so I have a special interest. But I recently went to meet our safeguarding team, and the looked after children's nurse was there, and I put a challenge to her with our CAMS transformation about how she is inputting into our CAMS transformation programme to think about the needs of looked after children and other vulnerable groups with the rest of the safeguarding team, so that when we are thinking about how we're transforming CAMS services, we're looking at the population with the most needs and we're making sure we're being responsive. So I think it would be a really important point that as we talk to you about our CAMS transformation over the next year, that we keep revisiting to make sure we're on track with.
And John?
Thanks. Thank you very much for the question. I know it mentions it in the paper, but it's probably worth just drawing out, and this is no way wishing to minimise. So when you disaggregate the data within our specialist service divisions between people on the neurodevelopmental waiting list or pathway versus those perhaps children and young people or adults who are known to our and open to our secondary mental health care services, there's a very considerable difference in terms of the performance. So for me, there's a correlation, though, between the management of care plans and risk assessments from a quality perspective and the way that we oversee our waiting lists, and not just people who are waiting for treatment or assessment, but actually the continued oversight of people who are on our caseloads. So if we have in place standardized patient tracking processes, we will ensure that people are seen routinely, and if there are any concerns around that, they will be picked up, but then we will also be able to review their care plans and risk assessments at the same time. So there's a number of routes of ensuring that we are continuing to follow up.
I was just going to add that measuring the extent to which people report being involved in the development of their care plan is really important, both by asking them directly and going back to the reference I made earlier to using AI tools to really mine data sets in relation to incidents, complaints, to really understand the extent to which people do feel involved in decisions about their care and treatment.
And Anna, please.
So, separate point. I just wanted to commend the exec on the work that you've done on inappropriate out of area placements, because I mean I've been on this board quite a number of years, and it's been a recurring theme and challenge, and I just want to commend you for the work that you've done on it, and the fact that you stay with it and it stays a priority, because it's absolutely essential to patients and their care. So thank you.
But and Cathy, please.
I was just going to pick up on Alma's point about the extent to which we're understanding subgroups within our population. So looked after children being sort of a classic example, really. And there was reference in the paper to the newly established Health Inequalities and Outcomes Group. So it'd be perhaps good to understand over time how that work will, use a sort of core 20+5 to identify those segments within our population and make sure that we're sort of targeting either work on waiting lists or whatever it might be to
Yeah. Okay, we will absolutely. Anything else? So we will now go to the board assurance framework.
On the, you will have had the BAF. I mean, it's been through a review, and as you could imagine, as we get towards the end of the year, there hasn't been any changes within the scoring. It's following review in effect. So I guess I'm not gonna, I'll take it sort of as read and then happy to take questions on it. I will say, and I think we're assured on this now because I've confirmed it happens, that all of the relevant BAF risks are assigned to committees and that they are all now going through the committee structure as well. And they're all then discussed and talked about at that stage before then subsequently coming here. I guess sort of a couple of key things associated with the BAF to highlight are we are currently working through with internal audit a review of our corporate risk register, so i.e. the level that just sits below the BAF. That will help us therefore as we move into our March board workshop when we're going to be thinking about the BAF for next year, and in light of the new strategy, the new corporate objectives, and what therefore does that mean in terms of a change to how we want our board assurance framework to look? What does it encompass? Having had the internal review for our corporate risk reviews, will then corporate risks at a level 5 will help us sort of just inform where we might want to put our attention, as well as what's on the corporate objectives. We will, as part of all of that, be thinking about also the assurance map and all the levels within the organisation that we're going to be taking those at the moment. And hopefully that will all come to fruition in another paper later on when we talk about the constitutional changes, because that then allows us to then do things that we need in Q1. So I'll leave it there. I don't think there's much else to say about it at this stage. I guess what I would reflect on is the BAF has definitely felt like much more of a live document this year. We've seen the scores change as the year has moved on. And for example, I'll take finance as an example. It started at 20. We've got toward the end of the year. We're clear on what we're going to be delivering. And therefore, that risk has gone down. Same within some of the workforce areas. So I think it hopefully demonstrates that we are trying to use it much more as a live document rather than as a static document, that it informs what we do in terms of the risks that we identify. Happy to take questions, Chair.
Any questions or comments? Paper that we're approving. Anna.
I mean, I agree. I sort of, now I kind of got the hang of it and I understand it better, and I feel that I can see what's happening over time, which is really helpful. And, you know, I suppose the things that jumped out at me, you know, the work that Teresa's doing on capital funds. I mean, this comes to QC every time, you know, that concern about you know, the lack of capital funds, that's such a big part of our you know, prevention work and our looking after people when they're in our care. So I'm really pleased to see the additions there. The other thing I didn't understand under clinical leadership, I'm looking for it's on page 4 of appendix 3 I'm on now, was the establishing a big MAC in Q4.
The Big Mac.
So I'd like to know what that is.
Okay. So the Medical Advisory Committee system.
Yep.
So there are Medical Advisory Committee is effectively a committee for senior doctors and senior managers at a locality area, and there are 4 across the trust, and sitting across the whole system is the Big Mac, and it's an opportunity to provide senior colleagues with state and nation information. So Usman's coming to talk about the finances, and Jane will be talking about the strategy, and I'll be talking also about some of the key matters that are affecting the medical profession. And then it's also a professional development day, so we're also going to be looking at the neurodevelopmental model as well. And this will be our first one, so we're just standing this up. So it's quite exciting.
First Big Mac. Okay.
There'll be a quarterly event.
Yep. No, that sounds good.
It's really good. I'm very keen to support clinical leadership, obviously, and I've been to a Little Mac I've been to a couple of.
You have, yeah.
Yeah, that's right. And I want to support the work that you're doing. Anil, did you have a?
If we're talking fast food, I'd rather look at somewhere else other than, but that aside, I think the clarity and forensic thorough in this BAF needs to be thoroughly applauded, so thank you. The question, if I can take colleagues to Appendix 3, page 3 of 12, under gaps in assurance. Amongst other things, it states there clearly and helpfully that this trust, we don't have the number of substantive employed staff required to ensure safe staffing. Lower down, it talks about staffing shortfalls within our clinical governance team. Now, perhaps viewed through the lens of the Shanley report and whether or not items are ragged at major 4 or above or not, are there any wards or indeed services that cause our colleagues today serious misgivings? Why? And what are we doing to address those issues?
I'll quickly just come on that specific point, but others may want to. So I think it's just the specific wording there, I think, is relating, and we can probably take this back in terms of being clear about the language, is relating to permanent staff. So that absolutely is the case.
Substantive, I got it.
Yeah, sorry, yeah. So it's the substantive staff. In terms of are our wards safe, etc., within the main IQPR document, all of the appendices set out for each of our wards, all the safe staffing levels, and you will see that we have consistently, well, I think I was going to say all year, but definitely as long as I've potentially been here, so even longer, always met our safer staffing ratios on a monthly basis.
So can I press, I looked at those appendices, page 36 to 43.
Yeah.
It seemed to me that it could be, correct me if I'm wrong, upbraid me please, a distinction between daytime and night shift. Is that correct?
There absolutely is a difference in the level of staffing we have day and night. Teresa's a much better place to talk about this than me, but to give assurance, we monitor those each month through the divisional directors of nursing, through the check and challenge process. There are always enough people from a quality point of view that sort of cover our core services, but there is at times gaps, and we then flex sort of between qualified and unqualified, which is why on some levels you will see 180% of the required number of staff, where we've types of staff to cover up those gaps. But let me not pretend to be the chief nurse.
Did very well.
I'll be pleased to see that wasn't on a couple of things to add.
Thanks.
It's a really important question.
So I had a list of points to feed back to you, and Usman's covered all but one of those points. And so the only other point that I would make is that there is a roster check and challenge process now that the divisional directors of nursing and quality complete with each ward team on a monthly basis. And that serves to educate often ward managers in how we best manage the allocation of shifts going forward. So we have that process in as well, but all that Usman said. So we monitor daytime, we monitor nighttime. The range that we're looking for is between 80% and 130%. If we're sitting outside of that range, so for example, if the fill rate is less than 80%, we'll do exactly what Usman says, and actually above the 80%, which is that matrons, ward managers and other clinicians will work in the numbers. And often what you will see, and you'll see it in the pack, is that when we are reporting over 130% fill rate, that is often related to acuity. So if we have a particularly high acuity, then we will bring more staff than the establishment in order to ensure safety.
Positions, Jane, and then
Mine's a more general point. So the way we run our executive team, just so you're aware, because that was a slightly strange interaction, is that we're exec directors first and portfolio holders second. And I have an expectation that all of the executives are able to talk across portfolios. And so that was a demonstration point that everybody is briefed across the.
I'm now looking forward to Teresa's analysis of the financial.
Finance report.
It's worth putting that into a context that this is the way we work as a team, that we're able to talk across portfolios.
No, I was thinking exactly that. You're talking from it.
Just a technical explanation around that the three comments that speak to the substantive workforce shortage in the gaps. I wanted to just set some context for the BAF at the start of the financial year, which is coming to an end. So as we mentioned, we've got 3 months to go in this current bath year. At the time this dynamic bath was started, we were at a nursing vacancy position of 25% of our nursing population. So our joint expectation was that the gaps would very much reflect that reality. And we couldn't have an effective bath that said everything was fine if we weren't saying we didn't have a quarter of the population of substantive nursing that we needed. If you then look in the column that has action plan to mitigate it, there's then been all the significant work that you see with the PMVA work, the patient, all the stuff that Teresa's been saying in earlier points that she's made. Position where we're now at is we now have the nursing vacancy position sat at 13.2%. When we started the year 25, we set a target for 20, which is where we thought we would get to by the end of the year, and we have gotten now to 13.2. So it's just to say that's a very good reflection of there's been a dynamic back, but the gaps were the gaps we set at the start of the year. So I just thought I'll add that lens.
That's very helpful, but you do know, if I conflate what you've said, thank you, with our earlier work, Colin, it's going to be more work for you if that's anything to go by in terms of how we venture towards the next year.
Hey, thank you very much. So we approved the board assurance framework report. Thank you very much.
And I just want to take, I know people have said about the BAT and the work that's gone into it. I just wrote Adam and the corporate governance team do a lot of work with all of the colleagues as well.
A lot of work, yeah. Thank you. The annual operating plan, Colin, our Chief Strategy and Partnerships Officer.
Thank you, Chair. So this is the Q3 annual operating plan update. It is in the same format as we've brought through the kind of Q2 report, so hopefully the structure of it is kind of sort of familiar. It brings together a number of different kind of sort of areas of work across the kind of portfolios. So setting out our kind of current position in terms of the delivery of the breakthrough objectives that we signed off at the beginning of the financial year, and then aligns that through to the quality priorities, the improvement programs priorities that we have. There's an update in addition this time just around the provider collaboratives, because I'm conscious that was in our annual operating plan, but was an omission from the Q2 report. And then you've got finance, people and performance as well. I'll just do a very kind of sort of brief overview and then sort of take questions and not dissimilar to the IQPR, bring in colleagues in the executive team as per their areas of kind of sort of focus. I think the Q3 position continues to demonstrate some progress across a multitude of kind of sort of different areas, but also there are some kind of sort of particular kind of hotspots and challenges. It's of note that the breakthrough objectives kind of position has significantly improved as a kind of sort of like an aggregate, but there is a kind of position of deterioration, which again overlaps with conversations that we're having in terms of thinking about our strategic priorities going forwards around the capture of outcome measures, sort of particularly within our improvement priorities. Again, you can see updates in main kind of sort of areas of change. Partly the reason for the community transformation programme being amber rated is linked to some changes to geographical footprint that have been agreed to support the Brighton area, which aligned with the systems development of the integrated kind of community team model. And we felt it was really important to make sure that we didn't try to go ahead of any changes that were going to give us structural difficulties in terms of integration further down the line. And also within that, we have now stood up our CAMS transformation programme. We have developed a sort of kind of CAMS case of change, which has been agreed internally within our transformation committees, currently being shared with the ICB kind of colleagues as well. And I think the key headlines for that show that within our kind of sort of CAM services, although we talk about them almost as being kind of quite a homogenous service, actually what we see is significant variation across the 3 places within which we kind of sort of operate, whether you're looking at clinical pathways, levels of financial investment, waiting times, capacity, etc. So there's a 2-year programme of work that has been established, and I'll bring more of an update back to the board in due course. And I think those are probably the main kind of sort of highlights. I'm conscious that there is always some overlap with the kind of the annual operating plan report with some of the other reports that we see that kind of come to board. So I think one of the conversations that we have is that in alignment with thinking about the development of the new strategy, how do we try to think about a sort of a strategy report that kind of goes forward, as opposed to something that probably has an element of duplication, as is currently sort of described. Happy to take any questions or field.
Thank you, Colin, very much. Yeah.
Observation, it's just in relation to the integrated community model, and in the vernacular, it's a shout out, especially for our CEO, but also Sean, attending those committees in common. I think, but for the way our CEO in particular has adeptly ensured the voice of mental health has been embedded into that discussion, and indeed those agreed priorities year one, it seemed to me that that important voice would have been lost, and the priorities could easily have not included all that this trust does so well. So just thank you, especially when you're dealing with people who are firm in their convictions and very sensitive. I'll leave it at that. Get the point.
Thank you.
I agree. It's the way it's presented as well, isn't it, Anil? I think we don't get very far if we say to our colleagues, we're just getting mental health. You know, mental health's not been mentioned. It's really about, I think, what we can offer as part of the solution for the system challenges. And I think Jane is very good at doing that. But I have to say as well that the integrated care system and board, as I was saying earlier, do take mental health autism very seriously and see it as a priority. So you know, it's sort of like an open door, but we've got to keep it up. Colin.
Building on that point, Chair, I think it's worth noting as well that within the sort of the system, they're seeing the sort of the neighbourhood mental health team model that we've developed and are rolling out as almost being the template on which to continue to further build out the kind of the integrated community team model. So it's kind of almost sort of being seen as a bit of a kind of a front runner, a bit of a kind of a template to kind of sort of work with, which again, I think is, you know, sort of real testament to the amounts of work that's kind of gone in across our community teams, because there's been a huge amount of change to do the realignment into that programme of work.
Okay, well, we've noted the annual operating plan. Thank you very much, Colin. No further points. I suggest we take a break, a short break, 20 minutes, and we'll come back then. Thank you. Okay, thank you very much. Welcome back. And let's get straight into the assurance reports from the committees. And the first one, Anna, is the Quality Committee.
Thank you, Chair. So I will take the report as read, and as you will see, huge amount of work in progress. No new matters for board. I'm pleased to say that we noted the BAF 03 and 04, so that's service user and care experience, BAF 3, and workforce sustainability, BAF 4, both hit their targets. You heard at the December board, you received the assurance report on the work within the assessment and treatment services, and I'm, you know, wanted to just note at this board that we're continuing to monitor this work, and we'll receive an update at the April Quality Committee, which will come back to you. So that area is something that Quality Committee is very focused on, and pleased with the progress that's being made in terms of the intensive and assertive community mental health treatment, and particularly the assessment and treatment services, which we know are a concern. I also just want to note discussions, ongoing challenges of bed capacity and quality issues across the provider collaboratives, and the other couple of points, the importance of recognising and attending to staff well-being and the need to support staff, especially those with continuous exposure to trauma. Mr. Treader's already alluded to that earlier in the meeting. We noted the progress on overdue incidents investigations. Again, I think that's work, as we've discussed earlier today, where progress is being made. On the quality priorities dashboard, we pleased to see a reduction in falls and the physical health checks now at 92%. We're also pleased to see that on sexual safety, which is another quality priority, 47 breaches, 46 resulting in no harm and 1 resulting in low harm. I think we're really beginning to see the impact of the use of data, and Funmi made a really good point about, particularly about the use of Power BI and Workforce, really helping to understand at the local level and to make timely and appropriate adjustments based on data. But I'll stop there. Happy to take any questions. I'm sure Teresa will have things to add to that as well.
What would you like to add, Teresa?
I would have added something about the flu and COVID campaign, but actually we spoke about it earlier in relation to Dinesh's question. So I think apart from that, nothing specific.
Anything else? Just to for me?
I wanted to, if that's okay, Chair, just to have an opportunity for us, because it's been peppered through conversations throughout the morning, an opportunity for us to have a board conversation around our staff health and well-being, because that's come up in different ways, just to share by way of assurance what we have done so far, and an opportunity to then pick up if there are other things that we need to do just from a board assurance point of view, also in view of the significant programs of change that we've had. And from a performance metric point of view, we usually an organization would gauge how we are doing in terms of our retention of staff through our staff turnover. And our staff turnover currently represents that we currently have more leavers than joiners, but we have a good narrative around that's because we are currently holding about 130 vacancies as a result of the programs of change. But we also heard earlier through the conversation we had with Anil, and I'm sure maybe in many of your site visits and conversations, staff members are holding a very large degree of discomfort and concern. So what have we done? We have held in December, we held a grief awareness webinar, and that was attended by almost 200 staff members and another 100 after that who have accessed this program. And why grief awareness webinars? Because we understood that the impact of change is often seen as grief by many. That has been 91% of the attendees, almost 300 in total, both live and recorded. 91% found it extremely effective. And I have had several emails after that asking for us to do more of those. We have held monthly dealing with uncertainty and change sessions, both for managers and for staff members. And probably most effective thing that I can say, evidence-based, that we've done is our wellbeing fund, which is a teeny tiny budget, but we had a budget to provide a wellbeing support for all of our staff members for this year. And as of December, 65 of 97 individual teams across the 6,000 staff have taken advantage of those wellbeing fund to do anything within reason. So you can't go bungee jumping with it, but it's for the team to think about what they would like to do, that is away from work, and that is trust provision for in terms of the time. And 65 teams from April to December have so far engaged in that. And I guess what I just wanted to showcase with that is that there is a lot of, sometimes we don't get that rise into the level of the board. And I just wanted to have that mention here to say there is a significant amount of work. It's not enough, but we are doing things, and we're constantly looking for the opportunity to do things that have the most impact for us.
And for me, just to follow on, I mean, you and I have talked about the trauma-informed workshops that, are being planned. I know we had one, we had a date for one, didn't we? And then it didn't quite happen, but that work is going to feed into.
Yes, as one of many interventions, because with trauma-informed, I think one of the things, our view with trauma-informed care is to not suggest that that's the only way to addressing trauma or concerns that people have. But yes, Celia, who's our current interim director of psychology professions, is planning a new one for April that the board will be invited to. So she is working with us, and there's going to be a new date in the diary.
Just, thanks for raising that. And actually, I was going to ask two questions about, what we're doing with staff. Just generally, like, what is our strategy in regards to like how we're dealing with workplace stress? Like, is there like, this is what we normally do? I mean, I don't want individual, just generally as a board, how are we tackling workplace stress? Another issue that we had were about like, racist incidents against our staff, and just trying to see where we are with that, how we're supporting staff on that one, or how we're making sure that our patients and the public are not harming our staff. Bit flavour.
So it's a very good question with regard to stress, because that has a direct effect on our sickness absence rates. That's currently going up at the moment, and 34% of the sickness reasons is due to anxiety, stress, and depression. Which because we're a mental health trust, that is expected, but because we're going through a program of change, we are seeing that uptake in that as well. We are doing three things. Most of what we're doing can be put into three buckets. One is the individualized support that we offer to the individual through the management of their sickness absence, and that takes varying forms, but that's in one category. Another big thing we found in terms of the poor management of people's experience of stress and anxiety is how their manager manages that. So there is something about how we provide support to managers to do it effectively. And it's not being done out of spite. Often it's done out of not being clear on what the process is. So we are doing some bits around that. And the third,
is that involving like training the manager?
Yes, we've just launched a training offer that is done through the HR business partners to all managers whose teams have sickness absence rates, so that there is that process in place that people can plug into, and we have on the shelf training that you can just access. So there's those two. And the third category is the wellbeing, really ties into the wellbeing fund. So we have a program, our health and wellbeing approach is a NICE recommended and NICE recommended 8-pronged approach to managing health and wellbeing in the workplace. So it's a very well tested strategy. Trauma-informed care is one of it, and we are using that framework within our very limited funds available to then be able to play with different tools. Because some people might go, I want an away day, and another person goes, actually, I just want access to a webinar, and another person goes, I would like access to come and shadow the board and see what that looks like. So it's really interesting to recognize that people's needs are very different, and we have to be very careful not to apply a one-size-fits-all to it. And that's where we're trying to offer a smorgasbord of options so people can find something that works for them. So what we're doing falls into one of those three categories.
And the issue with the discrimination?
The discrimination, we are recently relaunching what we're calling Operation Cabell, which came to our People and Culture Committee last month. Operation Cabell looks at workplace violence, discrimination, but looking at elements of racist incidents, because we've seen an uptake in that. That's being managed by our chief nurse, reporting into our People and Culture Committee. But the Operation Cabell is great because it has all the different agencies linked into it. So security, which links in from the CFO, And we have reps from operations, we have someone representing the workforce team, and we have the deputy chief nurse sort of holding the ring. So it really is an interagency approach to how do we manage and support staff experiencing this in the workplace.
I think that's really reassuring for, for me, especially given the current climate that, that we find ourselves in, so that, our public and our staff are assured that, as a board, we are totally on board protecting them from, whatever might be coming from outside.
But well said, Abiola. Yeah, thank you. I know, Teresa, you want to come in. Yeah, and the only thing I wanted to say is that we have governors, representative of our governors' bodies that observes committees, and the feedback I had last time round was it's an excellently run committee, the quality committee, and particular reference to the chair, how it's chaired, so that should be said. Teresa, and then we need to move on to the complaints and the report. Teresa and Jane.
Thank you. So, and the point that I would add to Opcabel is that one of the key partners is Sussex, so working really closely with us as key partners. So thank you for raising that point. I also just wanted to mention here that in June, board, we will receive a report linked to a health and safety executive report.
Stole my thunder.
Which completed a thematic analysis of 20 organisations across the country, with a specific focus on musculoskeletal disorders and violence and aggression to staff. So the report is out. We are in the process of analysing that report to then make further recommendations for learning for SPFT. That report will come through QC in April, and then it will come to board in June. So more discussion on that point via that report also, I would suggest.
Thank you, Jane.
So I was going to bring that up as well. So that's great because it was in my chief exec's report at the front, so I was going to tie it in. And the other thing I wanted to say, we often talk about stress and mental health in here, and we sometimes forget the physical health care. And so I thought I'd just put in the room some feedback I had from staff who have attended some sessions that Ms. team have put on about living with cancer, either as a carer of someone with cancer or someone who's impacted by cancer. So the health and well-being is more than just stress. It is our number one factor, but we need to remember the physical health care of our staff as well.
Thank you very much. Good. Dan, complaints annual report.
Thank you, Chair. I stole my own thunder by talking to this item under the IQPR item. So I will be brief. This is the annual report for 23-24. This is a continuous quality improvement programme that's underway at the moment in relation to complaints. As you'll see in the report, it flags the review of the current policy, which we have undertaken. We launched the new policy in September, and I referenced that earlier. Looking ahead, the key challenges for us are really understanding what people's experience of the complaints process is, whether it has been timely, whether we've achieved our ambition around clarity of content and tone of voice. And then secondly, the other point I mentioned earlier about really understanding what complaints and experience data is telling us in order to learn from that data and take robust action in response to it. So that's all I'm saying. That's the report, Chair.
Thank you very much. Okay, really okay? Oh,
just a sort of slight nitpicking. In your key findings, there's an additional sentence there which should not be there. Report writing guidance available here.
Let me take that away. Get that amended. Thank you.
You just need to delete that sentence because it's not a key finding and it doesn't sort of. Thank you.
You'll take that away. Thank you, Dan. Great. Please, Anil.
So, Chair, I'm going to conflate what I just heard, if I could, with something in the CEO's report. It relates to, it's described as the triangle of care, learning from complaints. I'd be curious to understand how you would characterise the learning that is needed set against the backcloth in your paper, what you've just said. So through the view of that triangle of care, so carers, their families, what does that exactly mean? What's the learning
In relation to triangle of care.
in particular, in relation to complaints and the learning from complaints that have been made?
So, by way of background, Triangle Care is a national initiative that we've signed up to as a trust, and it's about how we involve carers and how we respond to their concerns. I think the point around the learning relates to my earlier point about how we're, as well as responding to individual concerns and complaints from families and carers, what's the overall data set telling us? What are the themes? What are the hotspots in terms of service areas? How does that correlate, align with data that we're getting from incident investigations and other sources? But that's the real focal point for the year ahead. Is that answering your question?
I think it does in part, but it seemed to me, this was implied, and if I've got it wrong, correct me, it seemed to be implied that there was, in addition to questions around timeliness and effective communication to those carers, there was something more in the nature of the complaints being made to the trust. That may be wrong.
Yeah.
So it's not just complaints, it's also serious incident, PSI, sorry. I'm still out with the arc with the terminology, but the incident investigations, there is still coming up as a theme every now and again that families do not feel involved in care planning. They don't feel involved in the SI investigation in the way that they should do. They don't feel completely listened to. And if you think about the inquests that have happened recently, and particularly one where there was a PFD, the family member felt that they weren't listened to when they raised concerns about their relative going on leave from the ward. So it's about communication with our carers of our patients in the investigation, but also in the care and treatment day to day. And we've got the triangle of care gives us some assurance that we are moving in the right direction. I don't think it gives complete assurance. It means that we've ticked the boxes for that standard, but I'd want to go a lot further and really learn from the really difficult stories that particularly Teresa has to sit and hear. She sits with the families and hears some of their quite difficult experiences of our processes and our services that we wouldn't want any of our relatives to experience, and we need to go further on it.
Thank you very much, Kevin. Just to pick up on the related point. So what are we to make of what looks like the fact that most complaints now come from parents, statutory complaints? Is that a recent trend, is it? And why would that have changed?
In terms of complaints?
Yeah. From the statutory, sorry, statutory complaints received, that there's been a
parents,
yes, that there's been a rebalancing towards parents, and why would that?
So I haven't got the data in terms of the previous years in front of me, but certainly from reviewing the complaints that come through from parents and families, a common theme is waiting times.
Yeah. So the rebalancing might be because it's now exceeding the number directly from patients, right?
We have, sorry, Jack.
Yes, please, yeah.
So we have disproportionate number of complaints from CAMS, and therefore those complaints come from the parents, not from the children.
And therefore the waiting times.
And it's disproportionately about waiting times and access to services.
Right. Okay.
Yeah. Okay, so we receive and note Quality Committee Chair's report and the complaint. Much. Finance and Investment Committee, Anil.
Look, thank you, Chair. But bear with me, I should note it down. So I know that there's been a report prepared. Thank you, Adam, and your team. The meeting was held on the 24th of January. I'm going to look down at my notes, so forgive me, colleagues. The centrepiece of the discussion was fourfold. 1, draft annual plan 25-26. 2, draft capital plan, same year. 3, performance report, month ending 9. And 4, the financial recovery plan. In terms of the reality, as at month 9, the trust was in a small surplus of £36,000. That our balance sheet was, however, fortified in month 6 by a payment from NHS England of 18.6 million. In terms of the improvement, cost improvement target of 25.6 million at the beginning of this year, some 14 million pounds has been delivered, leaving approximately 12 million in the last quarter. Despite pressures in forensics, CAMS, West Sussex inpatient unit, we are forecast to deliver those cost improvements. I think it's noteworthy, however, to say, especially to my NED colleagues, that pay is just over 2 million above budget and non-pay nearly 3 million pounds above budget. In terms of the annual plan, applying the current run rate forecast is that at the end of this year, we'll have achieved an underlying deficit of 25 million pounds, an improvement of almost 25 million pounds from the start of this year. I think if I could just praise you the words of Usman's colleague Alison Gracie, she put it very well when she said, "This is a significant achievement, demonstrates the effectiveness of the current year plan, the hard work and commitment of all staff, and the collaboration with system partners. In my estimation, all those are facts that should be applauded." Born out of a number of external factors beyond our control and internal factors that I think one could argue that were not reasonably foreseeable, the underlying position going into 25-26 has deteriorated from a deficit of 25 million to just over 36 million. Current financial planning assumptions based on a 5% SIP target equal 27 million, of which currently identified schemes are almost 19 million, clearly a gap. But that leaves an underlying projected deficit of 9 million pounds. I'm sure we'll come to that in subsequent committee and board meetings. Now, national guidance having only been received, I know the team are working through that, but that position could deteriorate further by just over 10 million pounds since our starting point going into this year includes 10.4 million pounds of income that's yet to be confirmed by the system. It's important to, I think, that we're conscious of that. As an aside, however, I think in my estimation, the level of assurance provided around the numbers in the colloquial at that committee meeting was high. It was born out of well thought through planning assumptions, an acute understanding of the drivers behind the deficit, as well as well-made understanding of risks and mitigations. The draft capital plan, colleagues will remember at the beginning of this current year, that plan was 6.5 million pounds, whereas the ICS have been notified, the ICS have been notified this trust that the allocation next year may be reduced to just over 6 million pounds. And it's important to note, and there was a much, I think, important discussion around this at committee, that this is against a trust ask of 10 million pounds against a sum that that sum is well below the actual need that was estimated at over 16 million pounds. So 6 million apparently coming our way against a 10 million pound ask, which is very different from a need that's well over 16 million in terms of capital allocation need. The first call of that 6.1 million are projects that are bleeding in, come from previous financial years into the next financial year, an example of which is Langley Green, an additional allocation of 3.8 million on ongoing IT works, and ring-fenced amount for estates compliance, which is about 2.8 million, that actually is the lion's share of the 6.1 million, leaving no latitude. It's not some latitude, no latitude, as Osman will tell you in due course. I think it's also important to note that if I could draw my colleagues' attention to the messages to board that was in the report that you have, I'd invite you to read that, because the import of that is that we need to be clear-eyed clearly in the trade-offs that are necessary and the red clinical and other red lines that are going to be part and involved in the discussions in order to find that almost impossible conundrum between being financially viable and delivering safe, high quality, effective care. There's so much more we could talk about, Chair, but I think those are the centrepiece of discussion.
Summary, well chaired, well presented. Got to be said, within all that, the surplus, heading for a surplus this year is incredible and should be commended. Going into next year, that deficit, and I know we're working on plans for that, and it'll be part of discussions going forward, given that we're February now, a couple of months left with our really important negotiations, discussions with the Integrated Care Board and others. And on the capital side, we're reassured to a degree by central government around some increasing capital, but what you just described is not going to be enough. And again, it's conversations, tough conversations with our system to ensure that mental health does not get left out of any capital investment. Thanks very much. Usman, before we ask Abiola, did you want to add?
No, Neil's done a great job of it. I think just the one very brief thing just to just comment on. So Neil sort of talked about the fact that within the month 9 position, while overall it's at plan, there is an overspend on pay and an overspend within non-pay. In both cases, they're being offset by additional income. So some of the overspend within pay, as you'll see on the report, is related to what we always knew was going to be the stretch or sort of unallocated CIP, which is part of our mitigations plan that we sort of took through when we did the forecast paper. We said we had additional income that we would use to offset. So just to sort of square the full circle on that. And we'll talk some more about planning later on in the day.
Just following on from actually what Anil said, and just recognising that people who aren't at the committee are here reporting to my colleagues. I was at the meeting. It was a really good committee in terms of having people like Teresa and Oliver there who could bring in a non-finance point of view. So I really felt that I want to give assurance to my colleagues that we really did look at the numbers and what was happening from a non-numbers perspective to make sure that we were making the right sort of decisions. And that from someone who's coming new into the NHS, and maybe not everyone recognises, I don't think I had appreciated just how much pressure the finance team had in terms of coming out with the plans when we didn't get the numbers from the government as to what we had to work with, how much money we were going to have. And I don't think I fully appreciated that until sort of this last meeting. So to have got to where we have got to, the finance team have done a phenomenal job to get us to where we are. And we are going to see that things are going to be more difficult, but we have to just bear in mind that we don't actually know the numbers, some really significant numbers that you would do in the normal world when you're doing planning. Just wanted to make that.
Could I just add, I was remiss in not saying this, and I've made a career out of never commending accountants, but I feel like having paid them a lot of money. But I think we need to commend the accountants of this trust that the preparation prior, and indeed the reports presented before the committee, were as good as anything I've seen from the best commercial firms. So thank you. And indeed, in the committee itself, I know John, Oliver, Teresa, and others attended. It added to understanding, certainly as a NED, and dare I say it, the more important nuance around those difficult decisions that executive colleagues have to deal with every day. So thank you.
We were thinking earlier the skills and unique talents that we have, and you have a finance background and business as well. It's interesting that the comment you made about
accountants.
Compared to the world of business, it's good to have other parts of the wider economy, like for example business, to have to just get a comparison with.
I guess more of a comment, and just I think a reflection for us in the context of thinking about 25-26. We are on track to deliver the £25 million recovery programme, and I guess both Abiola and Neil talked about it, but the fact that Teresa, Oliver and John are at the Finance Committee is a reflection of the fact that the recovery programme was a multidisciplinary organisation-wide effort, and that we all do it. It comes through the Finance Committee, and I guess it's just, I say that really consciously now in the context that later we'll be talking about in a bit more detail about some of the planning stuff and some of the challenges, and just thinking, while it will sound really difficult, what we did this year felt really difficult 10 months ago, and actually we have by and large delivered it all. And I think it's just worth keeping that in mind as we go through it. But yeah.
Thank you very much. Thank you very much. Moving on to the audit committee. Well, apologies because we don't have Nitin here. So apologies. So we have the report. And I know, Kevin, you were
I'm happy to speak to it.
Would you? Yeah.
Yeah. Sure. I mean, I'll take the report as read. It was, I think I described it as a fun committee.
Oh, okay.
Fun. So the internal audit, you'll see there was, I mean, I guess this issue of job planning has been around for a couple of years and trying to get to somewhere near target. And one of the few times in history though, with actually quite a bit of pushback, I think, on the targets that were provided by the exec. I think we got to a place where I think everyone was happy with the plan to get it back on track. So it was quite good, but a minimal assurance rating wasn't great. Temporary staffing issue, partial assurance, please be assured that nobody showed up who wasn't the right person. Because the two issues were right to work checks and the identity checks, and I think it was reframed as perhaps a recording issue more than an actual issue. So we received assurance on that. That was quite good. And then on counter fraud, I think nothing significant to report there. Positive was on the losses and comp side, where we had improved our position by 2.5 million, which is really good on debtors, is that right? And last thing to say was there were no escalations from the committee I can see, although I think the job planning conversation got so heated it nearly was an escalation, but it wasn't in the end, so that's fine. So all in all, yeah, we're in the advanced state of planning for external audit for this year, and a lot of the committee did comprise of talking about the detail of what was going to go into the external audit, and that's just what happens at audit committee. So I think that was a summary of it, but it was one committee.
And just the one thing to, since the committee met, just to confirm that the internal audit actions related to the job planning have now all been, RSM have been assured that they have been done and therefore have subsequently closed them following the committee. I just thought it's worth noting because that has been I haven't said, a long 18 months, 2-year process.
Okay, thanks very much. So that's the audit committee. So really the last item, review of the trust constitution, this one.
Thank you, Chair. So you will have had the paper. I'll take it as read, but I'll just sort of take us through kind of what this is and why we're doing this. So you will all hopefully remember that at the board workshop when we met, we said we would be carrying out a review of the constitution in light of, I guess, it's been a while since we've done it. And there's been a number of changes, and we wanted to make sure that our constitution reflected both all of those changes, but also allowed us as a board to operate as flexibly as possible, recognising the sort of changing environment that we operate in. And it was also on the back of the governor task. I was trying to look for Simon. The governor task force that Simon and others colleagues have been involved in terms of how do we incorporate some of the learnings from that. So this report basically sets out some of those changes, and I think it's important to note that we did seek external legal advice. So this has been reviewed by external legal firm, and I'm confident in saying that therefore is compliant with our code of governance for NHS providers, and ensures that as we enter 25-26 with our new strategy and the things that we want to do, we have the most ability to respond to that. In particular, what does that mean? So it means we have the ability to generate extraordinary committees where they're needed without requiring to having to go sort of back through Council of Governors. And that's not to diminish any responsibilities from the Council of Governors, but it's just to recognise that there are times when extraordinary things will need to be done and committees, and in the time frame that we have, our ability to be able to respond and do that has then been created through this. It also allows us to make changes to our standing instructions. Again, that just gives us flexibility in terms of decision making and sort of creation and composition of board committees. So very explicitly sort of related to our functions. It doesn't in any way, again, take anything away from what the governors will be doing. That is all absolutely as part of the code of governance. And I guess the one last slightly important thing is that it does allow us to do things electronically as well, which is going to be helpful, I think. Saves us from always having to meet. On the back of that, I'm happy to take some questions. What I just wanted to be really clear on, all we're asking the board to approve today is proposed changes to the Constitution. That's it. There is also in the appendices attached some draft terms of reference for the establishment of the Mental Health Committee that we have been talking about for some time, and subject to any final sort of discussion points, draft conversations that we want to have about it, that would come through in April. We have also got a draft for a proposal around what a people committee might look like, but I want to just be really clear that that is a very, very early just draft. It is for discussion. No further decisions or discussions have taken place around it. And if we want to do anything on that front, that would therefore the next stage of that would be in April as well. And I think that's it from me, Chair.
Thank you. I think you explained it well, Usman, and in particular the People Education Research Committee. We did a lot more outside this board, yeah, so that's great. Any comments?
So if I may, Chair, I'm fully supportive of the re-establishment of the Mental Health Act Committee, and we've talked about this Equality Committee over a number of months, if not years, and that seems very sensible to me. And I would fully support, further thought before proceeding with an additional committee. I think there are issues around capacity for meetings on the exec side and the NED side, and that's not the most important, but it is a consideration. And I suppose I just perhaps a little bit more understanding about how it would add to existing structures, and how it would feed into Quality Committee in particular. So happy to support the proposal on Constitution and Mental Health Act Committee, and very pleased to hear that we're going to have some further discussion about the proposals around the other committee. Yeah.
Yes, Kevin and Anil. Who's first? Well, sorry, Abiona, I didn't see you.
No.
No? Let's go, Kevin.
Okay, just on the Mental Health Act Committee, so I'm clear, what's the next step?
It's here in draft in terms of reference, assuming everything between now and our next board meeting, there are no changes or particular things that we need to agree, then it would be constituted in 25-26.
Okay, at some point, right?
Well, we envision it. It's actually, I have to say, Adam might know the exact date. I think provisionally we've got some dates.
We've set out provisional dates for 25-26. Based on terms of reference for it meeting 3 times in that year.
Yeah.
So those are scheduled in.
Are the teams aware of these?
Yeah, we've had conversations with the integrated legal team.
Okay.
Yeah.
At the next board meeting, we will.
In effect, so the next board meeting, unless anything else happens, we'll just be noting that it's now been approved and it will now turn into a formal committee of the board.
And then I can leave. Great.
Reference here, if there are any additions, any amendments we made.
Exactly.
Yeah. And Anil.
Thank you, Chair. So first thing I'd like to say, I can only echo all that Anna has said. So it may be all too late, but I would question the efficacy of so doing. It's what's the added value to this organisation of having that particular additional trust. But then it's a question. But secondly, it's a nascent committee. I've looked at the terms of reference. Thank you. I overlaid not just, but in particular, the recommendations and the factual matrices behind the Shanley report in Manchester, Edenfield. It seems to me that some of those recommendations could perhaps be artfully woven in our terms of reference. And not that there are glaring gaps, I'm not suggesting that, but there may be areas that we can just refine it a little bit.
Yeah.
Just a thought.
Absolutely. So I just want to be really, really clear. So I will take we did this as much for convenience, just because recognise it was a February board, and then it would give us time to have discussion about it, ahead of us wanting to do something if we chose to in April, make the decision so that we've then got time to do it into 25-26. So I think we've got lots of time. I think later and tomorrow we can have sort of discussions about it, and we've got the board workshop as well in March, and hopefully in between that there'll be lots of ideas of how to do it. And I just want to be really clear, one of the reasons it is only here as a sort of draft is because we absolutely recognise the point about board capacity, and what some, we'll have to decide about how that works, but I think there'll be lots of opportunities for us to work that through in detail, sort of outside of the formal board.
You come back then, Kevin, then we've got Jen. That's fine, but just be aware that there isn't a Mental Health Act Mental Capacity Committee standing at the moment, and has been for the past 3 years. So it's all in abeyance at the moment, and therefore we're accumulating risk possibly around assurance processes, but that's.
Okay.
So I think the other change in the constitution, if I might, unless I'm wrong, is the change to the makeup of the governors that we have in here. I think it's worth noting. I've had a long conversation with Adam about this, because when I saw this, it was too late to come into here. But I have a concern that the constituent of the governors does not specify a clinician in any shape or form. It's done on geography and it's done on directorate, but doesn't stipulate that anybody should have any clinical background. So I had a query about that. I know the other bit is we are able to have a young person governor, 16 to 18, but we don't say we should have one mandated, and that would be something I would want in the constitution. So there are things within this constitution that probably, if I had sight of it before it went to legal, I would have shipped into it a bit more. But I think when we get to the standard operating procedure that underpins this, I would want it really explicit about young people and about clinician makeup within the governing body, because I think that gives us an added layer of assurance, and also recognises the young person doesn't have to be a cancer patient, but it recognises that we treat and we serve young people as well as adults.
Okay, and we have a chance to do that in further work.
We can do that. Yeah, we can take that outside of here in terms of further work. I don't think at this point the constitution that is drafted here is the one that we would go with. I think we would then have to work to see how we would incorporate, if we wanted to do some of those changes.
Standard operating procedure.
Yeah, exactly.
Yeah. Vote for the constitution.
Forgive me, Chair, should it not be that, I say as a former lawyer, that it's this board with respect that directs the lawyers, as opposed to it being the other way? So not that you were saying that, but it just felt...
No. So the lawyers haven't done this. What they've done is confirm that nothing in here is in breach of the code of governance, that nothing is in breach of the governance manual. We can happily make additional changes. I'm just saying at this point, for this iteration, we can do another iteration of this, and we would just end. So don't want to, Hampsons definitely haven't done this for, they haven't written it. It's our constitution. We are the owners of it. They've simply reviewed it to ensure that we are legally compliant with all of the things that we are required to be compliant with.
Yes, it's mindful just in terms of the council composition. Our next campaign for election for the council is in July. So the constitution that sets out the composition has to come through the board and then to the council. The council meets on Monday. So if we're planning to change the constituencies and we want to do that before July, then we may need to stand up an additional council to make that recommendation and approval. But to Jane's point, it's absolutely within our gift, and to Neil's, it's us that drive what those constituencies and classes look like. So we have the time and the capacity to do that, but it may just need an additional council. And I make that point because I'm really keen we don't go out to election for a composition that we don't want in terms of the future. So at the moment we have 34 governors. The plan in this proposal is to reduce that to 25.
Adam, in terms of another meeting, could we not have it minuted at the next council that the amendments that were made and then they're just actioned afterwards, so that we don't have to have that extra?
Very good suggestion. Yeah. Because we could do it anyway, and I think that a clinical representative of governors and a young person and we've got we've got the links and the ability to do that, it would be really good, really useful, given our, well, certainly going into next year, for example, our big focus around child and adolescent mental health services. So I think it's absolutely right. Very good.
Thanks.
So, so we are approving then the revised constitution. I'm grateful. Thank you for that question. We are closing administration. Any other business? Very much indeed. We'll break. Have I missed something?
No, and my agenda's different to yours, don't worry. I've got EPRR on mine too.
So we're closing business. Thank you very much.